Bismillahirrahmanirrahim. Today we are going to discuss three important topics. These topics are, first of all, cardiac achalasia. Then we will discuss the reflux esophagitis, and at the end we will discuss the foreign body of food passages. First, cardiac achalasia. Cardiac achalasia is a benign lesion of the esophagus which is characterized by absence of peristalsis, raised resting pressure, and no relaxation of the lower esophageal sphincter. This is the X-rays barium swallow showing these features. You can see here that this is the spasm at the lower end of the esophagus, with the body of the esophagus is dilated with barium held up in the body of the esophagus. This is a patient having cardiac achalasia. Types of cardiac achalasia. This is of two types. The one is classical cardiac achalasia. The second one is the vigorous cardiac achalasia. As far as the pathology of cardiac achalasia is concerned, this is characterized by the degeneration of the ganglion cells of the myenteric plexus, which may be due to an autoimmune process, most likely caused by viral infection. But there are some other possible contributing factors, maybe, for example, hereditary factors, genetic and infective mechanisms may be involved to cause the degeneration of the ganglion cells of the myenteric plexus. Incidence. This disease is equally seen in both sexes. While if we consider the age of the patient, it is mostly seen in third to fifth decade of life. Clinical features of cardiac achalasia are dysphagia, which is of long duration, and it is more to the liquids than solids. Solids pass easily due to gravity effect. Second important clinical feature is the regurgitation of food, especially at night. And third is the emaciation. Investigations. Apart from routine investigations, the important investigation is X-ray barium swallow, which will show bird's beak or rat tail appearance of the lower end and dilated body of the esophagus, and third feature will be air fluid level. These features are seen in X-ray barium swallow of this patient having cardiac achalasia. X-ray barium swallow findings and their reasoning in cardiac achalasia. The first feature is that there is an acute tapering at the lower esophageal sphincter and narrowing at the gastroesophageal junction, producing a bird's beak or rat's tail appearance. The second feature is that the esophagus above the narrowing is often dilated to varying degrees as the esophagus is gradually stretched over time. And the third feature is there is an airflow margin is often seen over the barium column due to lack of peristalsis. The third investigation is the X-ray chest, postero-anterior view. This X-ray may show normal X-ray. Sometimes para-aortic tubular mass may be seen, sometimes mediastinal widening with airflow level, and sometimes gastric fundal gas shadow, which is absent. These features may be seen in X-ray chest, postero-anterior. The fourth investigations for cardiac achalasia is the manometry. On manometry, there is no true peristaltic propagation. The resting tone of the lower esophageal sphincter is raised, and there will be incomplete relaxation of the lower esophageal sphincter. The fifth investigation is the esophagoscopy. On esophagoscopy, we see that the body of the esophagus is seen dilated. Secondly, the surgeon may see food residue taken a few days ago, and esophagoscopy is also mandatory to exclude the carcinoma, which is a rare complication of this cardiac eclasia. Manometry. As I have said, manometry is important and it is the key test for establishing the diagnosis of cardiac eclasia. A catheter, which is a thin tube, is inserted through the nose and the patient is instructed to swallow several times. The probe measures muscle contractions in different parts of the esophagus during the act of swallowing. Manometry reveals failure of the lower esophageal sphincter to relax with the swallowing and lack of functional peristalsis in the smooth muscle of the esophagus. Characteristic manometric findings in cardiac eclasia. These findings are number one, lower esophageal sphincter fails to relax upon wet swallow. Less than 75% relaxation is seen in majority of the patients having cardiac eclasia. Second, pressure of the lower esophageal sphincter is more than 100 millimeter mercury is considered eclasia. And if the pressure of lower esophageal sphincter is more than 200 millimeter of mercury, then it is nutcracker eclasia. Normally, the pressure is less than 26 millimeter of mercury. The third finding is that there is no peristalsis in esophageal body. And the fourth finding is that there is relative increase in intraesophageal pressure as compared with intragastric pressure. The treatment of cardiac eclasia. We can divide the treatment into three categories. Number one, lifestyle changes. Second, medical treatment. Third, surgical treatment. The lifestyle changes. Both before and after treatment, eclasia patients may need to eat slowly. They should chew very well. They should drink plenty of water with meals. They should avoid eating near the bedtime and raising the bed, raising the head off the bed or sleeping with a wedge pillow promotes emptying of the esophagus by gravity. After surgery or pneumatic dilatation, proton pump inhibitors are required to prevent reflux damage by the inhibiting gastric acid secretion. And the patients should avoid foods which can aggravate reflux, including ketchup, citrus fruits, chocolate, alcohol, and caffeine. Second is the medical treatment. Drugs that reduce the lower esophageal sphincter pressure are used. These include calcium channel blockers such as amphetamine and nitrates such as isosorbide dinitrate and nitroglycerin. However, many patients experience unpleasant side effects such as headache and swollen feet, and these medications often stop helping after several months. Second is the botulinum toxin, Botox. It may be injected into the lower esophageal sphincter to paralyze the muscles holding it shut. As the effect of this drug is only temporary and it lasts about 6 months, Botox injections cause scarring in the sphincter, which may increase the difficulty of later hilar myotomy. This therapy is recommended only for patients who cannot risk surgery, such as elderly people in poor health. Pneumatic dilatation has a better long-term effectiveness than Botox injection. The third type of treatment is the surgical treatment. Surgical treatment includes dilatation and second, myotomy. In dilatation, the dilatation is indicated if the patient refuses surgery. It can be one of these three types. It may be mechanical dilatation, it may be pneumatic, or and it may be hydrostatic dilatation. In myotomy, that is the esophagomyotomy, classical operation is called Heller's operation, which is characterized by myotomy of the narrow lower portion of the esophagus. Mucosa remains intact. Modified Heller's operation via transthoracic approach or transabdominal approach. It may be done to relieve cardiac arrhythmia. The second disease which is going to be discussed now is the reflux esophagitis. This is also named as gastroesophageal reflux disease, commonly known as GERD. GERD is an esophageal mucosal injury or inflammation of the esophageal mucosa that occurs secondary to regurgitation of gastric contents into the esophagus. Clinically, this is referred to as gastroesophageal reflux disease. Typically, the reflux disease involves the distal 8 to 10 centimeter of the esophagus and the gastroesophageal junction. Epidemiology. Gastroesophageal reflux disease is a very common disorder. In late 1970s and 1980s, 25 to 40% of the healthy adult Americans experience the symptomatic GERD at least once a month. Furthermore, about 14% of adults suffered from heartburn or acid regurgitation on a weekly basis, and 7% noticed it once a day. Prevalence of GERD is more in Western countries, which is around about 1 to 20%, relative to developing countries, which is around about 5%. Etiology or risk factors. These include pregnancy, hiatus hernia, obesity, excessive use of tobacco and alcohol, and the drugs which relax the lower esophageal sphincter. For example, anticholinergic drugs such as atropine, cyclopentolate, beta adrenergic drugs such as propranolol, atenolol, and calcium channel blockers such as nifedipine and amlodipine. Clinical features. The clinical symptoms of gastroesophageal disease GERD can be divided into two groups: esophageal and extraesophageal symptoms. Esophageal symptoms. These include heartburn, acid dyspepsia, regurgitation, and chest pain. Whereas the extraesophageal symptoms, which are atypical symptoms, they include cough, asthma, throat pain, aspiration pneumonia, global sensation, and hoarseness due to laryngitis. Diagnosis. Diagnosis of reflux esophagitis is made by history, physical examination, and investigation. In investigations, the important ones are X-rays, barium swallow, and esophagogastroduodenoscopy. Endoscopy. The endoscopic findings in GERD range from normal esophageal mucosa to erosions and ulcerations. Based on the presence or absence of mucosal changes seen on endoscopy, GERD is classified into two groups. One is non-erosive reflux disease, and second is the erosive esophagitis. Non-erosive reflux disease is defined as the presence of typical symptoms of GERD in the absence of esophageal mucosal injury on conventional upper gastrointestinal endoscopy. The majority of the patients with GERD have non-erosive reflux disease. In erosive esophagitis, this type is severe reflux esophagitis and is characterized by mucosal breaks such as erosions or ulcerations on endoscopy. Los Angeles classification of reflux esophagitis based on endoscopy. The reflux esophagitis can be graded from A to D. A is the type in which there is one or more mucosal breaks less than 5 millimeter in maximum length. In grade B, we have one or more mucosal breaks more than 5 millimeter but without continuity across the mucosal folds. And in grade C, we have mucosal breaks continuous between two mucosal folds but involving less than 75% of the esophageal circumference. And in grade C, reflux esophagitis, we have mucosal breaks involving more than 75% of the esophageal circumference. Complications of reflux esophagitis. These are number one, esophageal ulceration with hemorrhage. Number two, benign stricture formation or stenosis of the esophagus. Third, aspiration of fluids leading to aspiration pneumonia. And fourth, Barrett's esophagus, which is a pre-malignant condition. Normal epithelium of the lower part of the esophagus, which is stratified squamous epithelium, is replaced by columnar epithelium due to metaplastic change because of continuous inflammation in Barrett's esophagus. Treatment. Treatment is either medical or surgical. In medical treatment, we have following important points. Number one is elevate the head side of the bed at night and ask the patient to avoid stress, anxiety, smoking, alcohol, caffeine, non-steroidal anti-inflammatory drugs, soft drinks, and meals before going to bed. Take meals at least 3 hours before going to bed. All these risk factors should be avoided by the patient having reflux esophagitis. The patient should use antacids. Then he should use drugs which increase the tone of the lower esophageal sphincter. For example, metoclopramide, Maxlon. Similarly, he should use H2 receptor antagonist, for example, cimetidine 800 mg twice daily or ranitidine 300 mg twice daily, or proton pump inhibitor in the form of omeprazole 40 mg daily. Surgical treatment. Surgical treatment is anti-reflux surgery, that is Nissen's fundoplication. The gastric fundus of the stomach is wrapped or plicated around the lower end of the esophagus and stitched in place. In this way, the closing function of the lower esophageal sphincter is reinforced and thus preventing the regurgitation of gastric contents into the esophagus. Now you can see here that this is normal esophagus and stomach. Now you can see here at the lower end of the esophagus, lower esophageal sphincter is closed and the contents of the stomach which will not be able to regurgitate. But on the other hand, if a patient is having cardiac reflux esophagitis, in that case, in GERD, what will happen? There will be backflow of acid and stomach contents into the esophagus, and this will cause heartburn. And this occurs in lower esophageal sphincter, which is open in case of GERD. This is endoscopic view of the lower end of the esophagus that you can see here, which is shown by the arrow, the ulcerations which are present in the lower part of the esophagus. This is another endoscopic view showing you some sort of stenosis of the distal part of the esophagus due to GERD. The last disease which is going to be discussed now is the foreign body food passage. Now, patients having ingested the foreign body, often they present as an emergency case. This happening is very common in children, especially between 6 months to 3 years of age. Sites of impaction or lodgement of foreign body in the food passage. The sites are number one, palatine tonsils. Second is the base of the tongue, vallicula, piriform fossa, and there are certain normal nervings of the esophagus where the foreign body can lodge. These sites are number one at pharyngoesophageal junction, which is at the level of C6, about 15 centimeters from the upper incisors. Second, at crossing of the arch of aorta and left main bronchus at the level of P4, about 25 centimeters from the upper incisor teeth. And the third, the site where the esophagus pierces the diaphragm at the level of T10, about 40 centimeters from the upper incisor teeth. Foreign bodies which are commonly seen in the food passages, these are needle, fish bone, chicken bone, beef or mutton bone, and denture. This denture is very dangerous for the body. Similarly, food bolus, coin, button battery, safety pin, and marble. All these foreign bodies may be encountered commonly in the food passages. Alkaline button batteries are also very important these days because of the usage of these alkaline button batteries in certain electronic devices. Battery ingestion is potentially life-threatening when it is lodged in the esophagus. This is a medical emergency that requires immediate removal. On the other hand, when it is located in the stomach, it has been thought to be at low risk. 24 to 48 or more hours of observation are recommended in case of battery is seen in the stomach, but not in case of esophagus. A button battery in the esophagus should be removed within 2 hours after ingestion. If the patient does not show any symptoms, 24 hours may be allowed to observe. In case long objects are ingested, they should be eliminated within 24 hours regardless of the presence of symptoms. Fishbone. The most common site of fishbone infection is the suprahyoid area, which contains high soft tissue and bony density. This makes X-rays less reliable, especially because not all the fish bones are radiopaque. Victims or risk factors. First of all, the age. Children are the most commonly victims seen to have foreign body ingestion while playing. Similarly, loss of protective mechanisms, for example, use of denture. Similarly, carelessness, narrow esophageal lumen due to benign or malignant stricture. And sometimes psychiatric patients may also may ingest the foreign body just to commit suicide. Clinical features. Symptoms will be initial choking or gagging, discomfort or pain, dysphagia, drooling of saliva, respiratory distress due to pressure effect on the airways. Signs may be seen which are tenderness, pooling of saliva on ideal, and foreign body visible on throat examination or on indirect laryngoscopy. Investigations. So investigations we need are X-rays, soft tissue of the neck, AP, and lateral views. These both views are very important to locate the site of lodgement of the foreign body in the food passage. Second, X-rays, barium swallow, again APL right oblique views, fluoroscopy, and esophagus. Treatment. Treatment is esophagoscopy and removal of the foreign body. Second is cervical esophagotomy and removal of the foreign body. Third, sometimes transthoracic esophagotomy and removal of the foreign body. If foreign body has reached the stomach, then keep the patient under observation. He should given normal diet. Check stools daily for presence of foreign body. No purgative should be given to the patient to hasten the passage of foreign body. The foreign body will pass automatically in the stools. However, if the patient develops clinical features of intestinal obstruction, then laparotomy and removal of the foreign body should be considered. Indications of laparotomy are pain and tenderness in the abdomen, foreign body not showing any progress on serial x-rays taken after a few days. If the foreign body is 5 centimeters or longer, for example, a hairpin in a child below 2 years, or the patient is having pyloric stenosis. In all these indications, laparotomy should be considered. Now, this is AP view, and this is the right lateral view. A foreign body in the food passage. Foreign body in the food passage. A patient X-rays having a foreign body in the stomach, below the diaphragm, in the abdomen, in the stomach. A button battery which was removed after performing esophagoscopy. This is a meat bolus seen in the esophagus endoscopically. Thank you so much.